Hello and welcome. I'm Chris Ryan. I'm a clinical social worker at Boston Children's Hospital, and I'm the co-chair of the Social Work and Social Services section of the ILAE. We're thrilled to offer our inaugural webinar. We have two fabulous speakers this morning, today. Um, Before we get started, I'd like to just do a quick introduction of the social work section of the league. So the social work and social services section is a new section with the ILAE, and we will work to promote involvement of social workers and social service workers from around the globe in the care of people with epilepsy, and in the work at the ILAE. We're a diverse group made up of social workers, social scientists, community health workers, and others that are interested in psychosocial aspects of care. I do want to acknowledge our committee members who helped in the planning of this event and future events. We've got a really diverse group from around the globe that are supporting us. We welcome your interest in our section and certainly new members, and there are links to our contacts as well as a registration link on the ILAE website in the sections we have a website there. So we're hoping that you'll find this presentation and discussion enriching and informative today. And this morning, we're joined by Dr. Jade Parnell and by Dr. Rugare Mugumbate. Dr. Jade Parnell is currently a postdoctoral researcher in the Department of Public Health and Epidemiology in the School of Population Health at the Royal College of Surgeons in Ireland. She is currently working on Epidemiology projects supporting women with epilepsy, which she will tell you more about. Her background is social science research with expertise in body image and appearance psychology and the impact of stigma on psychosocial health and support. Following Dr. Parnell, we'll hear from Dr. Rugare Mugumbate, who is a doctor of social work, and he's the co-chair of the ILE Social Work and Social Services section. He's also the secretary of the Epilepsy Alliance Africa and a senior research associate at University of Johannesburg, South Africa, as well as a senior lecturer at the University of Wollongong, Australia. He's a member of the Zimbabwe League Against Epilepsy and founder of the Epilepsy Resource Center in Zimbabwe. And he previously served as vice president for Africa for the International Bureau for Epilepsy. So the format for today's webinar, each speaker will speak for approximately 20 minutes, and then at the conclusion of both of the presentations, we'll open up for a Q&A. You'll notice at the bottom of your screen, there's a little Q&A icon. You can enter questions into that, and we'll field those questions, time permitting, at the conclusion of our presentation. So without further delay, I'd like to turn this over to Dr. Parnell. Thanks, Dr. Parnell.
Thank you very much, Chris, and welcome everyone to today's session. I'm just going to share my slides a moment. I firstly want to start by saying a huge thank you to Annabelle and the rest of the team at the International League Against Epilepsy for being able to present today. It's a great opportunity to share the work that we're doing. So as Chris mentioned, I'm Dr. Jade Parnell, and I'm a postdoctoral researcher based at the Royal College of Surgeons in Ireland. And sorry if you can hear any loud rain, because it is raining at the moment in Ireland. Surprise, surprise. So I'd like to start by sharing a disclaimer, and that is that this research is funded by the Health Research Board, Epilepsy Ireland, and the National Women and Infants Health Programme. And additionally, I would like to mention that I will be presenting an overview of some results today, which are preliminary and are also subject to peer review, so they could change. But we are very excited to share both the project and some of the initial results with you all. I'd like to acknowledge some of the very important people that work on this project. So Dr. Aisling Walsh, who is the lead investigator of the EpiNo project, also based at the Royal College of Surgeons in Ireland, as well as our project team members who are listed here on the left, and additional collaborators, as well as, very importantly, we have some patient and public involvement panel members. And these are wonderful women who have epilepsy and are integral to this project and the research that we do. Oh, there we go. So the aims of the session today, there are two, and the first one is to understand why is it important to support and care for women with epilepsy. I'm sure you're all here because you definitely do see importance in this, but just to very much reiterate why it is important. And secondly, to learn about some of the research that is happening right now and being conducted to support women with epilepsy. So a bit of background then. It is estimated that 15 million women globally of childbearing age have epilepsy. It's a very positive thing to remind ourselves and everyone that many women with epilepsy can expect very normal pregnancies and pregnancy outcomes. However, their reproductive choices are complex and can involve many decision-making processes. Importantly, women themselves have acknowledged that their information and resources are inadequate and that there is a lack of awareness of the risks and risk reduction measures amongst both patients and healthcare professionals to support women with epilepsy. So I'd like to introduce now the EpiNo project, which is based in the Republic of Ireland, but some of the research that I'll be sharing with you is generally relatable for international audiences, and hence why we'll be presenting that today. So the EpiNo project was developed directly because women with epilepsy consistently reported that they needed more information, more resources from preconception to postpartum. The information and the project specifically targets women with epilepsy, as I said, in Ireland, but again, it will be very applicable generally as well. The project started in July 2023, but the duration is 2 years, so it will be commencing until July 2025. So we're about halfway through the project. The overall aim of the EpiNo project is to work with women with epilepsy, their families, and healthcare providers to identify health information needs along the continuum of preconception to postpartum, as well as identifying and co-developing evidence-based resources to support women and health professionals during this period. So there are 4 objectives within this project, and I'd like to share them with you today. So the first one is to review available resources. So this objective essentially is getting a lay of the land, kind of like a systematic review, but instead of published papers, this is actual applied resources that women with epilepsy and other people will be accessing. So we reviewed existing health information and education resources for women with epilepsy and health professionals along the same continuum I mentioned. Objective 2 then was more of a qualitative piece of work, and that was to explore the health information and education needs directly by asking women with epilepsy, health professionals, as well as respective family members, via in-depth interviews and assessing their needs and support. Objective 3 is where we're currently at now, kind of being halfway through the project, and that is to then prioritize and plan what health information and resources would be useful to support women with epilepsy. And that is via a real-time Delphi study. So in essence, there will be a list of potential resources and people will vote, and we will essentially get a priority list from top to bottom of what people think are important regarding resources and health information for women with epilepsy. And finally, based on that priority list, we will then co-design and co-produce resources or a resource. We're not sure what that looks like yet. That's very dependent on Objective 3 outcomes for women with epilepsy, as well as their families and health professionals to, again, help support their needs at these stages. So today, I'm going to be sharing with you Objective 1, and as I said, some preliminary findings. So Objective 1 was the resource review, and this is titled Health Information for Women with Epilepsy from Preconception to Postpartum, an Evaluation of Online Resources. And I will caveat that this is quite a useful method that could be applied to different aspects of epilepsy, but also other conditions in terms of really understanding what information is out there and how effective or the quality of that information. So the aim of this study was to, firstly, provide an overview of the type of information. So when people are searching online, what type of search results are they receiving for women with epilepsy from preconception to postpartum? From that, the results, we then established what the quality of these resources were. So it's all good and well having a number of certain results via searches, but are they any use? Are they actually robust in terms of the accuracy of the information they provide? So the first stage of the method was to collate the search results. So we searched for 120 websites, 40 videos, 40 apps, and 40 podcasts in chronological order via various search platforms. So it was Google for the websites, YouTube for the videos, iTunes for apps, and Google Play for podcasts because they were the most popular at the time. And I will caveat that the search was done incognito, so there was no search history that would have affected the results. But you cannot shield your location. So this search was conducted in Ireland, and that is important to recognize. Although that wasn't limited in Ireland, it was a global search, and that will be shown in the next slide. The search terms, there were 4, and these are indicated here. So again, it was around supporting women with epilepsy from preconception to postpartum. So these searches represent those. For the initial search results, these were screened via various exclusion criteria. So mostly the inclusion criteria was related to needing to target women with epilepsy. A significant number targeted health professionals, and so they were excluded based on that, as well as duplication of search results, which did happen often as well. In total, 43 resources were included for the quality assessment review. So essentially, from the 240 results, only 43 were included and met that inclusion criteria. So that kind of says a lot in some ways as well. From the 43 resources that were included, these were then reviewed, as I stated, for the second stage of this process. These resources were reviewed by 4 people, 2 academics, 1 academic and health professional with experiences in midwifery, and 1 woman with epilepsy. And I will note that previous studies that have done similar methods for reviewing online resources, not necessarily for epilepsy, but generally very infrequently include the users. So we're very proud to have a woman with epilepsy actually included in the review of these resources, and that's a real strength of this research. So we did review these via two measures. The first one is what's called a HON code, and that's the United Nations approved accreditation for only websites. So we could only do this with websites, not for videos, podcasts, or apps. And essentially, it's quite a binary yes or no. They either have HON code approval or they do not. And just for interest, you can download an add-on that goes into your web browser that lights up if a website is HON code approved. However, HON code approval was actually removed in terms of discontinued. So they don't continue to approve any other websites, but it will light up for ones that have been approved. But that's been discontinued in 2022. So that's just important to note. The second measure was Discern, which is the most popular validated instrument to assess the quality of health information on the internet. It includes 16 items and is regularly used in similar methods. So just to highlight a few of the findings that we had. So in terms of the types of resources that were included in the final quality assessment, majority were websites, fewer videos, even fewer podcasts, and no applications were included in the final quality assessment. Most of the resources incorporated all stages from preconception to postpartum, but as you'll see, predominantly these included pregnancy, and very, very little, only one included information specifically for postpartum. In terms of the resource creators, majority were medical and academic institutions that created the resources. However, there were a good few organizations that were not-for-profit and potentially for-profit. Although the search was conducted in Ireland, majority of the search resulted in countries that developed the resources were from the US, the UK, and then less from Australia, and only 2 from Ireland, again, despite the search being conducted in Ireland. So that just kind of gives an indication as to the relevancy of this information for specific countries. So when we looked at the final results for the quality, only 12% of the websites, again, only websites, were HON code certified, so 3 out of the 26. All of the websites that were HON code certified were based in the USA. Then when we looked at the Discern tool, this runs from a range of 18 to 74, and there are specific categories for each one. I'll show you in a moment. But the average for all the resources was 47.9, which is a rating of fair in relation to previous literature. However, you'll see that there was a varied spread across these buckets. And although predominantly they sat within the fair range, there was a relatively similar spread across the good and excellent, as well as the very poor and poor. So again, overall, the average quality for the information for women with epilepsy from preconception to postpartum is fair. However, this varied widely. Websites provided more targeted information for women with epilepsy, but there was actually no difference in the quality of websites compared to videos and podcasts. There were no applications included, and this was largely due to inaccessibility of the information, the apps requiring payment, and lack of specific information for women with epilepsy from preconception to postpartum. Resources typically target all stages, but postpartum is less included and actually of poorer quality. So there's a real gap there and a necessary need to support the information postpartum for women with epilepsy. Majority of resources stem from medical and academic institutions. However, actually, when we compared the quality of these, they had less quality compared to other organizations. So we think that that might be to do with just processes in dissemination and needing to be a little bit more considerate of the end user in mind. And resources were mostly developed in the USA, despite the search being in Ireland. So there is a need for quite country-specific information as well to represent the the health needs and the context within the support for the women with epilepsy. Okay, so I'm just bearing my time, and I want to share with you one final a piece that we found from the project, and that is via Objective 2. So this was the interview study where we specifically were assessing the women with epilepsy's information needs via asking them directly. So there were two aims, but I'm only going to focus on the first one here, which is the women with epilepsy. We did also collect data from health professionals, but I'm not going to include that today. So there were 34 women with epilepsy who were interviewed, which is a great amount for a qualitative research study. They were all living in Ireland, so just to caveat that. They were conducted online, average 45 minutes. They were interviewed and transcribed intelligent verbatim, and the analysis is reflexive thematic analysis by Braun and Clark. So two themes I want to share. The first one is the initial idea that women with epilepsy really emphasize the need for voice, autonomy in their own reproductive health. So these women with epilepsy who were interviewed mentioned feeling lectured, the lack of autonomy and inclusion in decision-making processes, that they were often being dismissed by health professionals, for example, catamenial epilepsy, and trying to express that that might be a thing, that health professionals kind of saying they don't really know how to support in those areas. And on the flip side, a real positive of the women just sharing that their need for independence, self-advocacy, doing their own research and finding out things for themselves to be able to support that process. So we are very aware that this is a systemic thing that could be applied to many conditions, but these data really represent support for women with epilepsy. And finally, I'd like to share that there was the other theme of preparedness and timing for when information is received. So this is similar to a systematic review by McGrath in 2014 that showed that women with epilepsy need timely information. And these women also expressed the need to be prepared for their decision to have a child, to be prepared for pregnancy, labor, but also to include that there's not always the best time. Sometimes they were unable to take that information on and had other things going on, but that they really felt the need to kind of not cross that bridge when they get to it. If they felt ready, then they needed to have that information at that point. So finally, there is a good impact regarding this research. Women with epilepsy express a need for information, and they feel like they need more autonomy and preparedness for their own care when it comes to preconception to postpartum. Women with epilepsy should have access to evidence-based health information resources, and this is vital because it is lacking to some degree and needs that support. And equally, health professionals and providers can use resources to support the needs and information for women with epilepsy. And off the back of the Objective 1, we will be hopefully disseminating a list of resources, including what websites, what podcasts, what videos, and we had included at the end, as well as their quality rating. So that can be used as a resource as well for women and health professionals. Huge thank you to the Epino team and the PPI panel members, as well as the participants in this research. And thank you all for listening as well. I'm going to stop sharing.
Thank you so much, Dr. Parnell. That was fantastic. Okay, now we're going to turn it over to Dr. Mugumbate. Thank you.
Thank you so much, Chris, for handing over to me. Thank you. Thank you so much, Chris, for handing over to me and for the introduction that you did earlier. Thank you to you, Jade, for an insightful presentation on women with epilepsy. Just thinking that my first research as a social work student in Zimbabwe in 2003, when I was doing my honors project, was on women with epilepsy. I remember discussing a lot the triple burden that women with epilepsy face, living with a condition that is recurring, being female, but also being of childbearing age. So your presentation resonated very well with that research that I did years back, but also it resonates very well with my presentation on strength-based perspectives in social service delivery in epilepsy. Also wish to thank Annabella for the work that you have done organizing this, but also Chris, my co-chair for the social work and social services section. So I've got 20 minutes. And before I get into my presentation, I wish to pay my respects to the Darawa people on whose lands I'm reaching you from. I'm in Australia at the moment. That's where I work. And I work and I'm reaching you from Darawa lands. And as is the norm here in Australia, you pay respects to First Nations people before you do an event such as this one, just to acknowledge the years they've contributed to country, or years they've contributed to keeping country, which is the same country I'm reaching you from now. Chris has already introduced me. I've got nothing else to add. I also don't have any conflict of interest to declare. Chris has also talked about the social work and social services section. Thanks so much, Chris, for that. As you said, it's a new section, but we already have 60 members, and some of them are in attendance today. So thanks, everyone, for that. I just want to focus on 2 points on this slide. What gives us strength as social workers, community service workers, social scientists, and the like. Our strength and inspiration comes from social science, especially social science research that we do or that we use the results of in our work on a day-to-day basis. As a section, we advocate, we showcase, and we promote the role of social science in epilepsy management, which is a huge thing, given that it's a dominantly medical field. So we are saying there is space for social science in there as well. And that links with the topics that we have today, the one already presented by Jade, and what I'm focusing on, which is on the strength perspectives in social management of epilepsy. But I would want to start here by talking about deficit approaches that people with epilepsy face on a day-to-day basis. It varies. These approaches are seen in families, they're also seen in the community, but they're also seen in schools and health settings, which is very unfortunate. So usually people with epilepsy are said to be seized. Unfortunately, that's where the word seizure comes from as well, but it's stigmatizing, isn't it? They're also, in other cases, asked to be the last to receive a service or to be sent to school in families. There's also stereotyping that happens, and a lot of it results in people being discriminated, being neglected, but also being rejected. There's also the issue of non-recognition of people with epilepsy, no participation in health services, their voice, as we had before. Their voice or their views are considered to be not necessary, and consultation often lacks. So this describes a deficit approach to delivery of social services. But what if we take a strength approach, and what would a strength approach look like? That's the thrust of my presentation today. So Strength-based approaches, they are very popular in social science, in the delivery of human and social services. They vary from community to community, from country to country, but also from region to region. Their interpretation will be different in the African region. They will also be different in the Asian and Pacific region. There will also be differences in the European region or the Latin American or North American region, but there are commonalities. What are these? The first one is people-centeredness. It's one key aspect of the strength-based approach. Then there's also social justice centeredness, the aim being to be inclusive. Then it's also contextual. In social work, we use the term environmental as well, not the ecological environment, but people and systems around people. So the strength-based approach is contextual, but it's also holistic. Just giving an example of Ubuntu, for example, in Africa, it looks at family, it looks at community, but it also looks at the environment and spirituality. Those are all aspects of Ubuntu. So when you are dealing with epilepsy in Africa and you are using an Ubuntu perspective, you would go holistic. Then there's also intersectoral approaches. There are also strength-based approaches because of the collaboration that happens with those kinds of approaches. Capabilities are valued, and they are valued a lot. I'll talk about this a bit at the end of this presentation, and I'll bring in the work of Amata Sen, who was from India, and has talked a lot about capabilities and what they can do to transform people's lives. Then in social work, I am referring to social work because I am a social worker, but also in other human and community services, you find the strength-based approach is used a lot. And as I said before, it is the opposite of the deficit approach. The deficit approach looks at what is lacking, yet the strength approach looks at what is the resources and the assets that could be used to transform people's lives. Now, I've got some examples from research. Some of it are very recent. Some of it, of course, is not very recent, maybe just about 5-6 years ago. The first one, this one is about people with epilepsy, and it's a very good and direct example. And what I want to focus on is what I've highlighted there. People's experiences, that's people with epilepsy, are not always negative. So why do we need to take a strength-based approach? It's because of this. There are positive experiences that we could bang on for the benefit of individuals, but also for the benefit of others who observe them and those around them. So experiences are not always negative. They are positive experiences. And I've got a specific example from my own research in 2017 with Gray, as cited there. In that research, we concluded that individual resilience acted as a strong coping mechanism that resulted in better employment outcomes. This research was on people with epilepsy in Zimbabwe, and we were looking at disability, employment, and social justice in the context of social work. And we used interviews and focus groups, and one of the key themes that came out was individual resilience, and that was showcased by people having a fighting spirit, being their own advocates, and having a mastery and acceptance of epilepsy, the condition that they are living with. So this was a key outcome of this research, individual resilience, which is positive. We did focus on the more positive aspects of living with epilepsy, more positive aspects that can come out of living with epilepsy, and individual resilience was one of them. It resulted in people having better employment outcomes. I've got 3 more examples. This research is from the UK. The first one by Kells 2024, and it's talking about social work and social science more generally. service users who were using a strength-based approach, they were found to, they reported positive outcomes, which is really very important, because the benefits of taking a service, a strength-based approach, are then very clear. Greater empathy, trust, and better relationships or rapport was built between service providers and service users. And I think that is what we require for social services to impact people this way. This fourth example is from Taiwan. And I've highlighted the words that have been used to describe the lack of a strength-based approach. It's pathological, it's alienating, it's directing, then also a single as opposed to plural approaches are used. So when we take a strength-based approach, we become non-directive as service providers. We don't alienate, but we ensure that the voice of the service users is heard. Then the final one is from Ebunye, and this research was done in East Africa. This was about disability more broadly, and the key word there is a strength-based approach results in better inclusion. So inclusiveness is a key outcome of strength-based approaches. So I've used these examples to showcase research that has been done that is supporting a strength-based approach in social work, social services, and human services more broadly. I would now want to turn to the work of the Epilepsy Alliance Africa. I'll talk about the strength approaches the EAA is using. I am part of the EAA. And at the end, I also talk about the gaps that exist. And I then end my presentation. So the EAA was found in 2019. I'm sorry, 2019 is not visible. It's covered there. And its main work is to integrate the work of social and medical professionals, but also advocates in epilepsy, and work from a holistic angle. It also centers its work on stories of people with epilepsy and their families, and it's also focused on local understandings of epilepsy. One of the key projects, which was a research that I contributed to in 2019 when the Alliance was formed, was to demystify names of epilepsy. As you see there, there's a list of African names of epilepsy. And what we were saying was that in most cases, we think epilepsy is the most perfect word. Seizure is the most perfect noun, but they are not perfect nouns. So we had to do this research to come up with the names that are used in Africa, but also to say our understanding as Africans, our understanding from the African perspective, they may have deficits, but they're also strength. So there were some names that came out that are used to for epilepsy and seizures that are not stigmatizing. As you know, if you have been following the debate around epilepsy and seizure, there's a recent article. It's a 2024 article by Chauvin. Simon Chauvin is one of the key researchers in the area of epilepsy, and it is titled, Should We Use the Word Epilepsy or abolish it? That's my edition, or abolish it. And Simon's conclusion is that we should abolish the name epilepsy. They have already done it in Taiwan, in China, in Japan. They came up with a name that says exactly what epilepsy is, and a brain disorder that results from abnormal electrical activity. So they created a name around that to run away from words or nouns of epilepsy that says it's about being seized, it's also about being crazy, and things like that. So for the Epilepsy Alliance Africa, there are several names that came out, and this process helped to demystify how epilepsy is viewed, and how at times we think names that are in English are the best, or their best representation, yet they are not. As you have seen, epilepsy comes from a word that means to be seized, and to be seized with what? Seized by a spirit, or something like that. I would also want to say a bit about this week. This week is Epilepsy Stripes Week in Africa. That's why you see me wearing a zebra scarf. This week is about awareness, it's about promoting awareness, and it's running from 23rd, that was Monday, to the 27th, that's Friday this week. And the theme is empowering caregivers, a journey of giving, receiving, and valuing care. So the focus there is care giving. That's the theme for this year. One more thing about the Epilepsy Alliance Africa that will relate to using a strength approach is that it uses Africa philosophy in its work, in its discussions, but also in its awareness raising. It bases its work on Ubuntu, which is the overarching philosophy in Africa. Ubuntu is about family, it's about community. It also values society, environment, as well as spirituality. The other values are relationships, respect, justice, community or collectivity, which we call ujamaa in Swahili language. There's also being holistic, which is muzima. Then also seeing a person through others. And in this case, it's about accepting people with epilepsy. There's also another key important aspect of Ubuntu. It takes a village to raise a child. So the whole village is responsible for epilepsy as well. These are key values that come from Ubuntu that the Epilepsy Alliance Africa is using to promote awareness in villages and communities, saying if there is a child with epilepsy, it takes us all to raise that child. We've got collective responsibility as villages. And that image in blue, it shows the different names of Africa philosophy in different communities in Africa. Now I want to turn to the social management process. This is used a lot in social work, but also other social interventions. It has got 4 basic processes. That's engagement, assessment, intervention, and review. For others, they may have more stages, but basically this sums up the social management process. Now I would want to look at this social management process in the context of strength-based approaches that are used by the Epilepsy Alliance Africa. At the engagement stage, what we often promote to members of the Epilepsy Alliance Africa is to be family-focused. That's an important value, and it's also contained in the Africa philosophy of Ubuntu. We also, I'll share a model or a tool that helps advocates and social service workers to use this process. The second stage, where assessment is done, we ask that assessment be holistic. We also ask that people think about Ubuntu in trying to be holistic in their assessment. As I said earlier, Ubuntu has got 5 aspects. The first one is a focus or a value on the family, a focus and a value on the community, then a focus and a value on the greater society, then a focus on the environment, and lastly, a focus on spirituality. Now, spirituality is really important because if you are doing assessment in Africa and you don't ask questions about spirituality, you will be missing information that will help you in promoting medicine adherence, in promoting the acceptance of medical treatment, because in most cases, medical treatment is actually the alternative. It's not the main stream form of intervention for epilepsy. Then for intervention, communities, we ask that communities are involved, but we also ask for a focus on prevention. Why? Because research shows that about 25% of epilepsies can be prevented. So by preventing epilepsy, for example, in East Africa, there is a huge prevalence of epilepsy that is a result of worms. It is caused by infections from worms, and those worms are eaten when people eat pork or pig meat. that is not properly cooked. So prevention then focuses on ensuring that when pork is eaten, it's properly cooked, and the pigs themselves are also kept in hygienic environments and fed with hygienic food. So that's prevention that we promote in the African context. Then lastly, we talk about review, and collaboration is valued there as a strength-based approach, as a strength-based intervention. But then in most cases, because of the recurring nature of seizures, the process does not end. It's not like malaria that you treat and it goes. You have to go back to engaging with families, to assessing the issues that are happening, including the issue of spirituality that I talked about. Because if you don't, people will default from medicine, and you need to be aware of their spiritual beliefs and the interventions that they are also taking, going hand in hand with medical treatment. Then you also go back to intervention, and also lastly, there is a review that happens. So these are the strength approaches that we promote, and there's a tool. This is 2022 research that I contributed to with colleagues there from different regions, Kisani from the Middle East, but also North Africa, Acevedo from Latin America. And we came up with this tool for it's a social assessment tool. What it does is to acknowledge the role of the family and community, but also to acknowledge the system around the individual, the organization, the school, the employers, and the like, to ensure that assessment is comprehensive. So it's a quicker way to assess the social issues and come up with interventions and referrals when they are needed. It can also be used to rate or to rank the social issues and see which ones should be prioritized for referrals or for social management. This is my final slide. I'll look at what is missing. I think from the work of the Epilepsy Alliance Africa, but also other works that I've been part of before in various capacities, there are a lot of issues that are missing. One of them is a focus on more structural or more systemic issues. For example, a national policy and national program on epilepsy is missing in most countries, but particularly those in the global south or in resource-limited settings. Hopefully, the IGAP will be able to contribute to some of these shortcomings in ensuring that countries have got national policies and national programs to tackle the challenge of epilepsy. In Zimbabwe, where I come from, there is a mental health policy. Within it, there should be a section for epilepsy, but in strategic plan after strategic plan, epilepsy has been missing, and there is need for more advocacy to do that. Why is this structural? It's structural in the sense that only government has got the resources to deal with epilepsy on a national level. Non-government organizations, health institutions won't be able to do that, but government will be able to deal with epilepsy in all regions, in all districts, in all provinces, and in all states. Hence the need for coordinated, more structural and more systemic approaches. Advocates for improved public services and national programs that links with the first two ideas, but a focus on education and training, as Amata Sen said before. Developing these capabilities is important for social management of disability, social management in health, social management in epilepsy. It's really important. In my previous research, 2017 research, it focused on employment and disability, and education and training were key issues, and there were key barriers for people with epilepsy who wanted to access education and build on their capabilities to be able to manage their own lives. And that links directly with income, livelihoods, and employment. So without capabilities enhanced, then the chances of having reliable income and livelihoods, but also sustainable employment becomes very, very slim for people with epilepsy. So my colleague Jade talked about women with epilepsy, and there is a big challenge, the triple burden, especially in resource poor communities. But as we have heard, even in Ireland, which is resourced, there are also challenges in terms of women with epilepsy. So that's another challenge. That's another big gap. And by focusing on marginalized groups in society, it's a strength perspective. Give them voice, but also provide them with opportunities to develop their capabilities, income, livelihoods, as well as employment. But another challenge that we face from a social science perspective, especially in the work on epilepsy, is that there aren't as many social scientists, there aren't as many social workers, community workers, community development workers who are working in organizations or associations dealing with epilepsy. So this creates a gap in terms of knowledge production, in terms of knowledge sharing. Just thinking about this social work and social services section. It started off as the social work section in 2019, but it didn't take off quickly because it was difficult to recruit people who were employed or working as social workers. So it has taken about 5 years to get to where we are because there aren't as many social service professionals who are working in epilepsy organizations. If there could be more social scientists working, I think there will then be more research, there will be more advocates, and there will also be more social science focused approaches that are brought in the networks or associations or even at the international level to ensure that we've got medical science as well as social science all contributing to reducing the burden that people with epilepsy face and improving their quality of life. So I'll end it here by saying Kanimambo, Zikomo Kwambili, Asante Sana. That's thank you in African languages. Thank you.
Thank you so much, Rugare. So we have a number of questions that have come in into the chat. I will do my best to get through as many as we can. Just want to let you know, in case we run right up to the end, that there will be a survey that's going to be put in. We really encourage folks to complete that. Also, we're very interested to hear from you all about what is of interest to you for future webinars. We're planning a number of webinars in the coming months. So please send us ideas, anything, any topics that are of interest for us to cover. Okay, so first question is for Dr. Parnell, and it's there's a number of questions on the same topic, so I'm going to sort of blend a couple of these here. There was this mention that the importance of including pre-adolescent girls or pre-pubescent girls in this education, and also question about or a statement about that this seems to fit well into transition interventions for young folks. We think about transition starting at 12, right, to try to develop into personal independence around health decisions, around epilepsy. And so curious if you could speak to both of those in your work.
Thanks, Chris. And yeah, thanks, Rugare, as well. That was a wonderful presentation and great questions too. Depending on when the diagnosis is given to a woman, if they are a young woman, then indeed the research and some of the findings that we have supports that these conversations need to start early. They need to be introduced age appropriately, but there are also important things to consider. One thing that health professionals kept highlighting was the sometimes difficult dynamic that it could have between the caregiver and the young person when they're trying to introduce topics regarding maybe sexual health and reproduction, and that could be a potential barrier. So completely agree. These conversations need to be early, and pediatric doctors do need to have more on their radar, and specifically pediatric neurologists, for supporting young women at an early stage to think about these things going forward. But also we have to kind of bear in mind the dynamics that could happen within the context, supporting the young person, but also potentially having caregivers there and them being, legally able to, make those decisions as well. So yeah, it's complex, but it is hugely necessary. Completely agree.
Thank you. And the next question I think could be maybe addressed by both of you, and it speaks to the importance of putting out guidelines about epilepsy first aid, particularly around anti-seizure meds for preconception, prenatal planning, and I think also the importance of having local supports embedded in communities that can distribute that education, particularly to under-resourced communities. So maybe both of you could speak to that point.
Do you want to go first, Rugare, or?
Yeah, thank you. Thank you. A good question. I won't be able to talk about the prenatal issues, but the community involvement. It's really important. One of the things that we've done is to come up with guidelines for first aid, but also first guidance. And we've made that distinction because first aid will be the more medical one, where you provide physical support when someone has just had a seizure. Then first guidance will then be the social support that you give when someone had their first seizure, or when they've got a seizure and they have not received first guidance. So first guidance will deal with where to get information. In this case, maybe it's pregnant women with epilepsy, or not pregnant women with epilepsy, women of childbearing age. They want to get information about epilepsy and pregnancy. You then refer them. That's first guidance. It's not first aid, first guidance. Where do you go? Maybe they also don't have the resources. At times, people asked to buy additional medication and they don't have the funding. Then you say, go and to social service, go to this organization and get support. Again, it's first guidance. And lastly, the role of community. Community does play an important role, because if you don't educate the community, they are not going to be able to provide the two. That's first aid and first guidance. So if the first person to see the person having a seizure, or in the family you have your seizure for the first time, and people are able to say, oh, this is what you are supposed to do, or it could be at school, it could be at a shopping mall. If that support is available, I think it will really be useful in supporting people with epilepsy to get the services that they require, especially when they have their first seizure.
Can I just add as well, thanks, Rugare, like to echo that, just to briefly mention that guidelines are hugely important. They are massively informed by the research. So we know sodium valproate is an effective drug when it comes to reducing seizure frequency, but it comes with many risks for women of reproductive age. But importantly, there are so many new drugs on the market and medications, and there's a very little research that is keeping up to date with the impact and potential risks of these. And the guidelines are informed by that research. So it's hugely important that that is also funded and very much up to date, so that we can inform the women based on the outcomes that we've assessed scientifically.
Thank you. So I think we have time for one last quick question. Let's see. This is for Dr. Parnell. Can you share what the possible resource outcomes might be once you have completed your project? The questionnaire mentioned, I think an app might be a great platform given the lack of applications found in your initial search.
Thanks, Chris. And thanks for the question. There was two very similar ones, and I know we have a minute left, so I'll be brief. But it could go any way. Essentially, what we've done is, from the interviews from the women with epilepsy and health professionals, we have collated all the points when they said this is what they would have liked. They would love to have had information-wise. And we've created a list of these. And then that's when people will then vote on these in the next stage of the research. So depending on what's prioritized will be what it is. Now, that could be an infographic, it could be an app, it could be a series of podcast episodes, videos. We don't know until we get that information from the women themselves. But in essence, anything, right, would be helpful right now. And an app is potentially useful because there's nothing out there at the moment. And apps do require specific updates and continuous evaluation. So we'd have to make sure it's feasible. But additionally, anything, like I said, would be a support at this moment in time for women with epilepsy during these stages. Thank you.
Well, that's about all the time we have today. I want to thank our speakers again for really great informative presentations, and the League for hosting us. Again, please look out for a survey. We really appreciate your feedback. And our section contact information and registration are on the League's website. We look forward to hearing from anyone that has interest in joining our section, and who and also about your topics that are of interest to you for future webinars. Thanks so much, folks.